Good afternoon, everyone, again. Thank you so much for joining us this afternoon. We apologize that we had to reschedule the meeting from last week to today. It was just impossible to know how it would impact the storm, how it would impact Florida throughout, and we didn't want to cause additional burden. So we had to reschedule, but thank you so much for joining us today. We are going to focus a lot on the data and the tools that we have developed for you and the processes so you can submit your data. But first, we want to talk a little bit about why. Before that, I'm going to ask you to please mute yourself unless you have a question. Then you please raise your hand or enter your question in the chat box, and we will ask you to join us in conversation. But just so everybody is able to hear well, mute yourself. And this webinar is being recorded because we hope to share it in the website in case anybody wasn't able to join us today. Dr. Sappenfield is our FPQC director, and I'm going to ask him to please join us to tell us a little bit about the background of PACC.
Welcome, everybody. We're glad that you're here. I think sometimes we think that data is an extra effort you need to do by quality improvement, and you just need to think about it as the driving force behind quality improvement. What gets measured, gets managed, and gets improved. So why postpartum care? Just to remind you some of the highlights from the kickoff, for those who were not there. 1/3 to half of all of Florida's pregnancy-related deaths occur after the mother leaves the hospital. We have, our rates are very close to that of the nation, and we have some of the highest maternal mortality rates in the developed countries. And again, this postpartum period is where a lot of these deaths occur. To add to that, we actually have more women dying of drug-related deaths during and after pregnancy than all maternal complications put together. And 3/4 of these mothers die after leaving the hospital. So we have the great chance to impact what's happening to mothers in terms of mortality once they leave the hospital. And not only mortality, 50% of strokes occur within 10 days. 20% of postpartum mothers experience mental health disorders, many of which are never identified nor managed. And 40% of mothers do not attend their postpartum visits. So in the PACC Initiative, we're trying to reshape this focus and rechange what needs to happen so that we not only think about the baby after the birth, but we really think about the health and health care of the mother after delivery. Next slide. And most importantly, based off of studies that have been done qualitatively, women really would like to improve postpartum care. Women feel like there's really a lack of satisfaction with what happens now because it's happened so much later. They feel disengaged. They sort of dropped off after prenatal care, and there's this one last stop, and that women, really wish they could get back in earlier and have more help with their own health. It's what's happening with them, and not just the baby. Next slide. ACOG now recommends that mothers be seen within 3 weeks postpartum. They give you a range. That's why we're promoting the 2-week postpartum health check. The idea that you would come in, get your blood pressure checked, see how breastfeeding is going, identify mental health issues that may be starting to occur early on, making plans for contraception, especially if they want an IUD placed postpartum. The whole idea here is to optimize not only the health of the infant, but the health of the mother as well. Again, this initial assessment should be scheduled based off of risk, but it should be ongoing based on needed. Again, that comprehensive, is everything okay visit should be at 6 weeks, but we really need this early one to occur. Next slide. In fact, the way we would like to sort of look at it is to reshape this whole idea of postpartum care. Like with prenatal care, there's a whole series of visits, and it's looked at as a continuum. We want to move that idea of a continuum into postpartum care, starting with the early postpartum visit. The idea there is you would start with that, you would then move towards the traditional 6-week postpartum visit, and then transition women into women's care. And with Medicaid planning to extend eligibility for women up to 1 year after delivery, once the emergency order of Medicaid is lifted, this is really the plan not only by ACOG, but what Medicaid wishes would happen. Next slide. So all of this leads to our aim, and I'm going to turn that back over to Dr. Rubio.
Thank you, Dr. Sappenfield. So FPQC has chosen this initiative because of the need for postpartum care, and we want to really focus. So you will see that every single one of our measures and aims is directed to providing these 2-week postpartum visit and education processes and guidelines to support this effort. And then a couple of extra assessments that will happen during hospitalization to make sure that women go home safe and stay safe throughout the postpartum period. And so you can see that our aims is that by June 2024, the FPQC participating hospitals will, 1, increase the percent of patients with a 2-week postpartum visit that has to be scheduled prior to discharge by 20%. And 2, that we want to increase the patient postpartum medication the same by 20%, and that includes the benefits of early postpartum visits, warning signs, and family planning. For the baseline, that will be established with the first quarter of hospital data, since we don't have another data source to help us with baseline. To achieve this, we have identified 3 important drivers. Those are our primary key drivers. You can see that those are the processes for a maternal discharge risk assessment to be established and to arrange early postpartum visits. The second one is related to patient discharge education, and the third one about clinician postpartum education and engagement. So, education is set to support the first one, but each one of them is going to have additional activities and processes that need to be put in place so we can all get to our aim, and that can be seen in the secondary key driver. We showed you this a million times in the kickoff, but in case you weren't there, this is just our theory of change, the graphical representation of the things that need to happen at your facility that will help you achieve the aim. So whenever you don't see progress, you don't see change, you need a new idea, go back to this graph and start to go through each one of those lines and identify the things that are missing or that need to be, pushed forward. Now, for the data, we really wanted to integrate all of these tools. So when we look at the measures, you're going to see that every single one of these secondary key drivers are going to be measured, either by collecting data at the patient level or collecting data at the hospital level with guidelines and policies. And that's what we're going to dive in a little deeper today. But think about this key driver diagram as we go through it. So as I mentioned, there is going to be 2 types of data or 2 levels of data that we're going to be collecting. The first one is at the patient level, and we're going to be looking at patient demographics and how the postpartum care and referrals are at the patient level. We're also going to ask you to collect data at the hospital level, and that is staff education, standardized documentation processes, and policies and guidelines to support PACC. And those are related to education, to assessments, to referrals, but you're going to see that in a minute. Let's get started with patient level data. And for that, we're going to review the data collection sheet that we have prepared for you. We shared that at the kickoff. It's also available in the website. Following up this webinar, I will send you the tools by email. And all of it is because we really want you to review everything that we're going to collect. That's going to be your first task. You need to figure out if your EHR already collects this information, or if you're going to have to set up a different system to collect this information, either by paper, which is not ideal, but until all of the information is set up in your system, there has to be a way for you to collect this. Now, I know that many of these things are already collected in your EHR, so hopefully it won't be many things that you will have to add. So in the demographic section, you're going to be collecting information on the date of the delivery, and we're just going to collect month and year to keep the identifiers away. We don't want to cause issues with your data user agreement. So we're not collecting the day, we're only collecting month and year. We also wanted to know if the discharge happened on a Saturday, Sunday, or during a holiday, because remember, the heart of the initiative is going to be the postpartum visit, the scheduling that early postpartum visit. And we know that during the holidays and the weekend, it may be a little more difficult. We still want you to set up a system to do it, but we understand that during those days it's going to be a little harder. So we want to know which ones were done on Saturday, Sunday, and holiday. We're asking you to collect maternal age, and that we're only asking you to report completed years at the time of delivery. Please do not run up, even if the mom is, let's say, 30 years old and is about to have a birthday next week, still just report 30 years old. We just want to have a standardized documentation, so completed years at the time of delivery. We're collecting information on the type of insurance, and that's Medicaid, private, self-pay, others, or unknown. We do allow you to check unknown, but we track unknowns closely. So please don't overuse it. I know that sometimes we just don't know, but those are hopefully going to be the minimum number of patients reported. Whenever possible, make the attempt to gather the information. We're also collecting mother's race, and here we ask you to check all that apply. So you have white, Black, Asian, and other. Again, we are providing unknown in case this was impossible to collect. But now we know that systems are really putting an effort in collecting this information better, much better if it's patient self-reported rather than, just assigned. For mother race, we are collecting whether of the patient was Hispanic, Haitian, non-Hispanic, or non-Haitian, or unknown. And then for the prenatal care, we're asking you if prenatal care started on the first or second trimester, on the third trimester, if the patient had no prenatal care, or if it's unknown. For mother's preferred language, you have English, Spanish, Creole, or other. And for the route of delivery, you're having vaginal or cesarean. Why is it important to collect demographics? It's because it informs case composition and allows us to track population change over time. We're going to be looking at those measures, and we want to make sure that if we have, a big change in the measures, we want to make sure that the population hasn't changed. So that will help us in that sense. But more importantly, it will help you disaggregate your measures to identify differences between populations. So how we now want to have an equity lens on the things that we do and make sure that whenever we find differences in populations, we allow for more resources or more help when possible. By having these demographics in the data collection forms, we will be able to give you disaggregated measures so you can assess those gaps and hopefully provide additional resources for more vulnerable populations. This is also because one of our aims, the overarching aim, is to provide respectful care. And by identifying those vulnerable populations, we're doing just that. For postpartum care, so in the data collection form, the second section is going to be regarding postpartum care. There are 5 questions, but truly it's 2 questions related to assessments and then 1 regarding education. So let's look at it. The first one is about the maternal discharge risk assessment. And we're asking if that was performed for the patient that you're going to be abstracting the record for. So if you were at kickoff, the maternal discharge risk assessment is a tool that the team developed. It's the picture is right here, and you can see that it's asking about 7 conditions. The ask is that women, when they are admitted for delivery, this risk assessment is performed, and whenever you find those issues, appropriate referrals and coordination of care is started early. So you can see that if the patient had chronic hypertension, gestational hypertension, preeclampsia, eclampsia, maternal heart disease, and number 1, for example, you have the minimum recommended referrals and services that they should be connected with underneath. And so for every one of the conditions that we are tracking, you're going to have the recommendations. So this tool needs to be adapted for your EHR. Again, please, during this time, you will have to look at your EHR, where these things are being collected and how they're being collected, or it may be completely new to your facility and you will have to institute it, right? So this assessment is available as a poster and also as a paper. It's available on our website. And it definitely, you will need to standardize documentation and find a better way to track it. The second questions, or the set of questions in that section, is regarding patient education. And here we're asking you if the patient was verbally instructed on the benefits of early risk-appropriate postpartum visits or post-birth health checks, and given the written materials. You're going to notice that we ask if the patient was verbally instructed and given written materials for all 3 questions regarding education. So we want to make sure that we provide the adequate education patients need. We don't want just to hand them a paper form and hope that they read it. We want to make sure that we review it with them verbally so they grasp a little more of what we're trying to do. And I know many of you already do this for postpartum medication when you do discharges. But we identify 3 things that are really, really important. The first one, I just said it, is the benefits of the early risk-appropriate postpartum visit. We want to make sure that if it's scheduled, the patients attend. It's important that they understand why we want them to attend and why we are really concerned about keeping continuation of care. The second section is about postpartum warning signs. So we know that A1 and CDC have very good materials on it. Your hospital will have to decide which one they want to share. But it's very, very important that women know what to do in case of an emergency, or if it's not an emergency, who they need to call. So that is what the postpartum warning signs is all about, right? Making sure that they know when to run to the emergency room, call 911, or call the OB. And the third one is regarding pregnancy spacing, family planning, and contraceptive choice. So all the educational materials that we gather are available in our website, fpqc.org/PACC. And again, here's something that needs to happen at your facility. You need to standardize that documentation to make sure that when your abstractor goes into the medical record, actually finds, note that the education was provided to the patient. This is the patient education trifecta. First, you have the post-birth health check and why it is important to go, what is going to happen, and who should schedule the first visit. We are asking that the hospital staff schedule the visit for the mom. We know that at some places it's not possible at the moment, and you may ask the mom to schedule it for herself. But at the end of the day, it's important that you keep track of whether or not that postpartum visit was actually scheduled. So whether it's the mom, which is not ideal, or it's the hospital staff, you need to make sure that that is documented in your medical record when and how it was scheduled. But the education that is one of the pamphlets we have available for moms to attend their post-birth health check. The second one is postpartum warning signs from A1. You can also use the CDC one. That's up to your hospital. But those warning signs really, really need to be shared with moms. And then the third one is regarding contraception. That's a pamphlet that FPQC developed. And, it goes through the many options that families have for family planning. So if you are sharing all those 3 documents, you could pretty much check all those boxes for education. And then the 5th question on that section was whether or not a postpartum discharge assessment was done just prior to discharge. So this is something that we also introduced at kickoff. In the maternal mortality review committee, we identified many times that vital signs were not taken right before discharge. And sometimes women are discharged with high blood pressures and end up having an event after, discharge because we didn't check one more time prior to discharge. So we want to make sure that that actually happens. Those vital signs at discharge are very important. So we're asking you to look at, the EHR or establish a system to make sure that that assessment happens just prior to discharge and that the person doing the assessment provides adequate response to any abnormality in the vital sign. So if you have a blood pressure that is higher than 160/100, a provide needs to be alerted, and then you have to hold discharge, for example. So you have, each one of the vital signs listed along with the response underneath. So for data collection, again, we're just going to ask you if this was done or not. So your team will have to determine if you are going to use the poster or if you're going to put this in the EHR, and you're going to have like an alert to make sure that providers are doing this. But at the end of the day, this is something that will help patients go home safely. And we also ask you to please find a way to standardize documentation so it's easy for the abstractor to figure out if the postpartum discharge assessment was done or not. For the postpartum visits, which again is the heart of the initiative, we're going to ask you how many days post-delivery date where the postpartum visits is scheduled prior to discharge, and that is with an obstetrical provider. Some women are going to be needing maybe cardiology or other specialties. This question is specific to the obstetrical provider, and that can be their midwife or their OBGYN, whoever is looking after that woman. And that scheduling needs to happen prior to discharge. And here again, we're asking you to check all that apply because you may be able to schedule the early postpartum visit, which is up to 3 weeks. So if it happened at less than 7 days, 7 to 14 days, 15 to 21 days, or if you were able to also schedule the 6-week postpartum visit. In some places, that's what's happening. They're scheduling the early postpartum visit and the 6-week postpartum visit. So you would check 2 marks here. You would check either one of the first 3 and the 4th one. Or if it was possible to just schedule one of them, you could please mark the one that applies. Here we are going to ask you to pay special attention to the early postpartum visit. That is what's new, what's not a standard of care for all patients. We know that, high-risk women or women that had a cesarean are having those early postpartum visits, but women that had a vaginal non-complicated delivery are not. And that is what's new about the initiative. We want to make sure that all women attend a postpartum visit. So we need to make sure that that is being scheduled. So please pay special attention when you're abstracting for the data or when you're documenting to document that early postpartum visit. In the hospital level measures, one of the things we ask you to do is to do a scheduling flow diagram and specify who, when, and how the postpartum visit is going to be scheduled and documented. That is really going to help you to standardize your documentation. So please go through that as one of the first things that you tackle for the initiative. The last section of the patient-level data collection form is regarding comorbidities for high-risk patients and referrals. And so when we talked about the maternal discharge risk assessment, I mentioned to you that we're going to be tracking several comorbidities. And so these are the ones, right? We're going to be looking at chronic hypertension, gestational hypertension, preeclampsia, eclampsia, maternal heart disease, or related conditions. We're going to be looking at thromboembolism, C-sections, or 3rd or 4th degree vaginal lacerations, whether or not there was a positive screen for substance use disorder, if the patient referred feeling unsafe at home, or you have a positive screen for intimate partner violence, if you have a positive Edinburgh postnatal depression scale, or if the patient just requested additional community resources, right? Or if you have any other type of high-risk condition, that doesn't fall into the ones that are listed. You will list it at the end. But the idea here is that if you have a high-risk woman and you mark any of these boxes, the next thing is going to be the referrals, schedule, and the medications provided prior to discharge to make sure that high-risk women was connected to the right services. So you will be marking, and again here, this is check all that apply. You will be marking if they receive a referral or scheduled referral for a specialty appointment, mental or behavioral health appointment, if they were connected to Healthy Start or a home visiting program, or Medicaid case management, if a hospital financial counselor was hooked into treatment, if they receive appropriate medication, and then if you are providing the naloxone kit for those women that had a positive substance use disorder, or if you're providing the prescription. So that is all that is collected in the patient level data collection form. Again, I will send you that data collection again, just so you can review it. And I'm going to ask you to please go again with your team and identify those things that are not being collected by your EHR at the moment and figure out a way to collect it. Because starting January, we're going to start collecting the data for this initiative, and you will need to have those in place. So I usually start talking about inclusion and exclusion. But this time around, I left it for later because we don't have a lot of exclusions. This is going to be something that applies for basically all women that come to deliver to your facility. So you can see here, the inclusion criteria is all women who are discharged home, regardless of infant outcome, who were admitted for delivery. In your exclusions, you're going to have pregnant women who are in observation status or seen in the ED. So they didn't come for the delivery, they are just being observed. Pregnant women who are not admitted for delivery, women who are admitted for delivery but die prior to discharge or are transferred to another hospital. You will not include those in the sample. So if you think about it and you're a large hospital, you're probably thinking, I cannot report all this information in 100 patients if that's how many you have a month. Maybe you have more, right? But we thought about the burden of data, and we don't want to cause a lot of burden. We just want to collect enough information to inform the initiative that is significant and that you will be able to use. And so we have pretty much two buckets. If your hospital has 40 births per month or more, which is going to be the vast majority of my hospitals. So if that's your case, you're going to report 20 systematically selected discharges deliveries per month. So that means every month, at the end of the month, you're going to get the number of deliveries that you got. And if you have more than 40, you're going to choose 20 systematically. And I will let you review and I will share with you how you're going to systematically select those cases in a second. If your hospital has less than 40 births per month, it's going to be much easier for you. You're just going to report the first 10 delivery charts per month, right? So much easier. And the reason why we want that number and why the selection is different, the process is different, is because we want to make sure we're collecting information of women from different shifts, different times of the month, different days of the week. Just we want to see your practice throughout the month, not just a couple of days. So that's why the process is different for each. So if you are one of those hospitals that has more than 40 births per month, at the end of the month, you're going to take that total number of delivery discharges that occur, and you're going to divide it by 20. So let's say your hospital had 105 discharges in January. So in February, at the beginning of February, you're going to take that total number and divide it by 20. If we do 105 by 20, that's going to be 5.25. And we're going to ask you to always round down, right? So for this case, it would be 5. 5 is going to be your number. But with that number, you're going to select that every fifth charge so for this example, that will be, you're going to report data on every fifth every fifth chart for all the deliveries that occurred in January. So that will give you 20 cases, but always round down. Even if the number, for example, if you have the division and your result is 5.9, you're still going to round down. You're going to always do 5, because if you do 6, you won't have enough cases. You will run out of cases. If you do 5, you're always going to have 20 records to report. So always round down. And you know, that's the selection process. I will share this in an email so you have it handy. But if you have any questions, or if at some point you're having hesitations about the number that you need to use, please don't hesitate to ever reach out. More than happy to help anytime. Okay, so that's about the sampling. So now you know if you're going to report 20 cases per month, or if you're going to report 10 cases per month. Remember, that's going to be based on the number of deliveries that your hospital has per month. If you have more than 40, you're going to report 20 patients every month. And if you have less than 40, you're going to report 10 patients every month. And that's going to be throughout the initiative. So every single month, that's going to be the number of reports that you have to do to the FPQC website. With that being said, one of the first things that you're going to see in the data collection form is this study ID number. So FPQC does not get any identifiable information from your patients. We don't get the medical record number or the names of the patient. So the only way that we know when we talk to each other about the cases, which case we're talking about, is by a number that you designate when you start to submit your data to FPQC. So in the form, we have a study ID number at the top of the page. So we are going to ask you for the first patient whose data you will be submitting to FPQC, please assign the number 001, and then number consecutively all the patients that you're going to submit to FPQC throughout the initiative. And that way, you know, if we need to check data for a particular patient, I will email you and tell you, hey, I have a question about a study ID number 60, and you will be able to go back to that case and find their medical record number and help me check that information. And sorry about that. So this is something that is important. It's important for you to keep track of your cases. So we're going to ask you to please keep a log of your patients, of the patients that you have submitted data for FPQC. We ask you that once you have your sample of the number of patients that you're going to submit to FPQC, write down the medical record number and then the study ID number that you designate to that patient. Once you submit your data, our system is going to give you a survey return code. So also keep track of that. So in case you need to change anything on the record, you will have access to the record. Please, this log is only for you. Do not submit that to FPQC. We don't want to know the patient identifiable information at that level. So this is just for you to keep, to help you keep all your cases organized and to help us go back to the correct case in case we need to check anything that was submitted to the portal. Now for the process. So the process is pretty straightforward. If you have done an initiative with FPQC in the past, you know this by heart. If you are new, it's very simple. Once you identify the number of patients that you will submit to FPQC every month, you are going to, if you are the data lead of the hospital, you're going to abstract the medical record of that patient using the form. So this is the form, you know, the one in the center. The form that will help you collect the information for each one of your patients. So you're going to fill one form per patient that you are submitting to FPQC. And once you have that information, we are going to ask you to enter that information in the data portal that we use through RedCap. So this is how it looks. And it's pretty straightforward. Once your hospital submits the data user agreement to us, we will send you the link. And many of you have, I have about a third of hospitals already with an executed EUA. So if you have a DUA, you will receive the link. If you don't, please make sure that that is getting done, because otherwise I will not be able to send you the link to share your data. But once you have your link, you just put it on a browser. You don't need a password. You don't need anything additional, just the link. And once you go into that portal, you select your hospital name, and then you start to input the data that you collected in the data collection sheet. Once you submit again, you will get a return code. So just make sure to put that back in the patient log. And that's it for the patient level data. Ben is going to walk you through the hospital level data. Ben, go ahead.
Thank you, Estefania. My name is Benjamin Gessner, and I'm the data analyst for the FPQC. And today I'll be helping us through the hospital level data. Next slide, please. So as you see here, these are our structural measures, and this is what it will look like within your data collection sheet, as well as it will in REDCap. And I will go through each one of these measures with you, and I just need you for the moment. The scaling is a Likert scale, and I will go over that in the next slide to explain how each scaling works. What are structural measures? Structural measures help us measure how your hospital is doing within the implementation of this initiative and how we are doing in assisting you with this. So if you look in our first, we asked to what extent your hospital has developed the process flow to schedule an early risk-appropriate postpartum visit and a counter prior to discharge. We have had some questions about that in the chat, and we are answering them, but it helps us see how we are doing with that to help you. To what extent has your hospital aligned policies, guidelines, and/or procedures to support risk-appropriate postpartum visits and counters prior to discharge? To what extent has your hospital implemented universal maternal discharge risk assessments, established a system to ensure that all patients receive recommended and documented postpartum education and discharge information, developed a strategy to engage and educate inpatient providers and staff using initiative promotional and educational materials, developed a strategy to educate outpatient providers using initiative promotional materials and educate them on billing and coding for early postpartum visits, implemented periodic education and engagement of new hires, implemented periodic education and engagement for ER physicians and for staff about pregnancy/postpartum care, including postpartum screening and care practices, and ER established standardized verbal screening for pregnancy now and during the past year as part of its triage or initial assessment process. Now, that may be a lot. We do derive all of these out of our measurement grid, and we will go through them throughout the process. Next slide. So as you see here, just to reiterate, our structural measures help us assess where your facility is on implementation within our initiative. Next slide. Next slide, Stephanie. Okay. So this is our Likert scale, and it is a 5-tiered Likert scale that starts at not started and goes all the way up to fully implemented. This kind of gives us a good gauge as to where you are within your implementation process. Now, not started is that you've received our material and you have not started planning and have not started implementing the material yet. And that is our first scaling. Planning would be that you are planning the groundwork for the initiative and the education of all your staffing, but you have not started implementing it yet. Started implementing is within the first 3 months of your implementation process, everyone will be within the started implementing scaling. Implementing and fully implemented, although very similar, do have one key difference in that implemented has less than an 80% compliance after at least 3 months of implementation, and this would be deemed not routine practice, while fully implemented has had more than 80% compliance after at least 3 months of implementation. This would be a routine practice. Next slide, Stephania. So next we have our staff education. And as you see on the bottom, we just want you to report cumulative percents of the percentage of nurses and the percentage of OB doctors and providers who have received education on the following topics: the benefits of early risk-appropriate postpartum visits and post-birth health checks, the process, guideline, and/or protocol for facilitating scheduling the early postpartum visit prior to discharge, the documentation of scheduled postpartum visits, and the components of post-birth health checks. Now, we understand that documenting cumulative percentages is very, very difficult within most facilities, and With the amount of turnover that we have in hospitals everywhere, it is very difficult to have a standard denominator and to keep our percentages very similar throughout the process. With that being said, if your facility does have the capability to take a very accurate percentage of the amount of nurses and OB doctors and providers, we do recommend that you use this. If your facility does not have the ability, we just ask that you make as accurate of a guess as you can as the percentage of nurses and OB doctors and providers as you can. And with that, I will be handing it back off to Estefania.
Thank you, Ben. So yeah, he has walked you through what we're collecting at the hospital level and the scales. This is the form that we do have available for you in case you want to see all the measures together and maybe use it to collect or use it to gather ideas of what needs to happen next. And, you know, periodically, we're going to send you a link, pretty much like we do for the patient level measures. You will get a link. And again, you don't need a password or anything like that to submit your data. You just go in the link and submit what's new, what has changed, or what has remained the same for your facility. We include a graph in your report of what you have told us. So if in that report you see that something is not accurate or has changed, either contact us or submit another survey to update your hospital level measures. Another thing, once you have seen the patient level data and the hospital level data, you may think that many of our measures are repetitive. And the reason why you're going to see several things in both forms is because we really wanted to make sure that it's instituted at the hospital level, you know, so as a structural measure, but then we also wanted to collect at the patient level to make sure that it was happening at the patient level. So as a process, we wanted to be, to make sure that those two things were coordinated. So they may seem a little repetitive, but they are at different levels and they inform different things. In your sample, in your report, you will get two types of graphs. The first one is just a run chart. If you have done quality improvement in the past, this is the most basic graph of quality improvement. But it's very effective to let you see if you have made an improvement or if you have plateau or if you are on the opposite end of things, regressing, right? And so for every single one of the measures that we reviewed today, you will get a hospital-specific graph to quickly assess your progress. And you also will receive a graph that will let you see how you compare to other hospitals in the initiative. So we have 77 hospitals participating in PACC, right? And this graph, pretty much what it does, it divides the 77 hospitals participating in the initiative in 4 groups, depending on the rate of the measure. So let's say that this is scheduling postpartum visits, right? We organize the hospitals from the highest rates to the lowest rates and divide them in 4 groups. So 25% of hospitals with the highest rates are going to be in the green, and 25% of hospitals with the lowest rates are going to be down in the red, and the ones in between are going to be the blue and the purple. So the black line is your hospital. With that, it's very easy for you to see if you are among the hospitals with the highest rates, the lowest rates, in the middle, and how you are moving over time. So that's very, very useful when you want to see how your practice compares to others. We collect data to inform progress and outcomes of your work, and because it will help you identify areas of opportunity and strength. So please do not feel like we're collecting data because of judgment of any type. We just want to maximize learning. This is a collaborative. We want to learn from each other. And data collection is the heart of quality improvement. We can only change what we track. And so when you collect your information and submit to us, please know that we keep it very confidential. Whenever we have coaching calls or, you know, we share with the state, we only share aggregate numbers of your outcomes. And we only use it as a way to track progress and to give you additional resources when needed and when possible. We are going to ask you to review your data every month and to evaluate and guide improvement. It has to be used to prompt discussion and action. Before, I had mentioned to you that, process precedes outcome. So if you are instituting a process and you're keeping track of that data, and you're discussing it with your teams and you're finding ways to implement and better the process, your outcome will come. But it needs to be an active process. It doesn't just happen because you're participating. It happens because you're putting in the work at your facilities in implementing these strategies and finding ways to make it work for your facility. We also, even though we're just getting started, we also ask you to create a system that can be maintained long after the project ends. So when we were going through their presentation, and we mentioned that this needs to be set up in your EHR and it needs to become part of your practices and policies and guidelines, it's just thinking about sustainability. We want to make sure that the gains that you get during the time participating in the initiative are well sustained over time. I had shared this with you in the past. Every single month, you're going to be joining us in a coaching call. You're going to submit your data. You're going to get your report. But really, when things start to happen is when you discuss and disseminate that data report, and when you identify those opportunities that are going to be feasible for PDSAs or for changes at your facility, and you actually implement them. So data is an important aspect of QI, but it will only help you if you use it to guide your actions at the hospital level. Again, this is our key driver diagram, all the measures that we have reviewed today. If you see this with the data collection forms that we have shared with you, you will see that every single thing that is a secondary driver is being measured. And so you will be able to see over time how you're doing. I shared the first part of this graph at kickoff. We are ready to go to the second section of the graph, which is starting to do the learning sessions and the PDSA cycles to gather your team and start implementing the initiative. So I hope that today we share with you the tools for data collection that are going to help you to start thinking of the things that need to happen at your facility. At kickoff, we also talked about the secondary outcome measures that we may be able to share through the Agency for Healthcare Administration about emergency room utilization, hospital readmissions, and postpartum visit attendance. Hospital readmissions, we are looking at several comorbidities, and we would love to give you those rates. But at this time, we are not ready to share that information. We want to get together with key partners to provide you that information adequately during the spring. We are trying to set up a webinar for you all to hear from our partners about the strengths of those measures and also some barriers that there may be. We do know that there is a delay of 6 to 9 months on that data, but we do want to evaluate it and keep track of it. So please know that we are working on getting that data for you and getting the right people to tell you how you can use that data. Again, I did have a couple of requests last time. I'm going to request them again for those teams that haven't been able to complete yet. Make sure that you track the completion of your hospital data user agreement. If we don't have a data user agreement, unfortunately, we won't be able to share the links with you. If you have any changes in your PACC team, especially your data lead, please let us know. We do have resources for the new data leads that join. We want to make sure that we talk to them and we connect through Zoom if needed to give them the tools and the knowledge they need to be successful. For everybody that has a data user agreement in place, I will send you the link to submit your hospital level data in December. This is your baseline, so don't worry if many of the things were not started, or we may have chosen a couple that we're planning, or if your staff education is 0%, that is completely okay and expected. Don't hesitate to submit your hospital level measures because your numbers are low or not as positive as you wish. It's completely expected that at this time, we're just getting started. Many of those things are going to be either not started or planning, and 0% for education. But we really need to have a baseline. So please make sure to submit that in December. And your patient level data collection, which is the past, that's going to require more effort because it needs to, you need to figure out if you can abstract it from the EHR already, or if you need a system. That is going to start in January. And your January data is going to be due on February 15th. The 15th is the date that you need to submit your data every month, and it's always for the month prior, right? So the first time that you will be submitting data for FPQC for this initiative will be February 15th, and then all the 15th of the months following. Okay, I want to open the floor for questions. I saw that the chat was very active. Thank you so much for sending so many questions. Thank you, Dr. Sappenfield, because I see you have responded many of the questions. What other questions are pending? I don't know.
Stephanie, the only thing I would add to what you said is if you do not have your data use agreement, we still encourage you to collect your data on the forms so that you can submit the data, because although we're collecting data in December, it really takes about 3 months to get good baseline data. So please, although you don't have your DUA and you can't submit it to us, do go ahead and collect the data and save it until your DUA is processed.
Absolutely. Also, if you're having difficulties with your legal department or anybody at the hospital is giving you trouble, we do have the IRB determination that we have to do at USF for the project, saying that this is not human research, this is quality improvement, right? So this is not human research. We have that determination. If that is going to be helpful for you to get that DUA approved by your facility, please let us know. We can share that with you. Or if there's any questions, at any level, please don't hesitate to reach out to us. We have gone through a couple of iterations, and so we're more than happy to jump in and help.
And our data use agreement is pretty standardized. We've been using it for 8 years. There's nothing, a lot that's changed. So although we let your lawyers do some tweaking, it should generally be acceptable because it's been acceptable over time repeatedly.
Mm-hmm. So I see a couple of questions. Let me see. Will you have the patient education in other languages, namely Spanish and Creole? Yes, we are working on that. Spanish is already on the making. I think we have a community partner that is working on the Creole. But yes, we will have that available. There's a question about baseline data. For the hospital level data, that is, your structural measures and your staff education, I asked that you submit it in December, because that is just one point in time for your facility. So that's your baseline for the hospital level measures. For the patient level measures, that is going to start in January. Data collection is going to start in January, and then you will submit those cases in February. The baseline will be the 3 first months of the initiative. So that will be January, February, and March. We combine them and we use that as the baseline for the patient level measures. I hope that was clearer. I'm sorry about that. The data submission process starts on February for your January cases. And again, remember the 15th is the day that you submit your data for the previous month. I don't know, Ben, Bill, do you see any other question that is pending?
Yes.
The data collection, you can go.
Marcy had asked, because we have to systematically choose the 20 patients, does this mean we cannot start abstracting the 20 patients until after the end of the month? This then gives us only 2 weeks to complete the data collection.
Yes, that is right, because you need the total number of deliveries that you have during the month. So yeah, you will have to wait until the last day to know the true number and to calculate your N. We had asked in the past if 2 weeks, and that has been true for other QI initiatives, where 2 weeks is enough time to complete data collection. But if you're having trouble or, because of your system, something is going on, please contact me. I'm sure we can figure out a way. But in the past, we haven't had issues. 2 weeks has been enough most of the time.
We should be
This is
able to
something
come
we
up
can
with
discuss in coaching calls too.
We
Sorry,
should
go
be able
ahead.
to come up in the mechanism for you. So if your hospital, that's a major issue, we just need the data, and Dr. Rubio and I can certainly come up with an alternative way for you to be able to do that so that you can start early if you need to. Generally, for most hospitals, that's not an issue, but we will accommodate to whatever your hospital can do.
And Mildred had asked, does a nurse visit in the OB clinic count for a postpartum visit?
The nurse
Yes.
in the OB clinic, yes.
And so does a telehealth visit also count as a visit. So it does not have to be in person. It does not have to be a physician.
Yep.
Just
The
confirming
slides
about
will
the
be
data
available.
collection for December. Is the data collection for December collected in December or collected after December?
No, data collection for the patient level measures starts in January.
Right. The other data you want in December?
That's
is
the
due-
hospital level data. That's just
that's due in
processes.
December by when?
By January, first month of January, for those that already have a DUA.
Thank you. How do you know if you submitted a DUA? Well, you won't get a data link until you do, and you'll start getting very nice notes from Dr. Linda Detman saying, we still need your data use agreement.
Mildred asked, in the previous, there has been a handoff of the rules, definitions, and metrics. We do have, that's the measurement grid. It's already published in the FPQC website, but I will make sure to add it to the documents that I email to you following up this webinar. That's a very technical report, so we were hesitant to share it with you all today. It just, provides the name of the measure, the numerator and the denominator of how we're going to calculate it for your report, and any caveats if there is any exclusion or anything of the sort. We don't have exclusions for this initiative that are, specific to measures. So it's a little bit simpler this time around, but I will make sure to share that measurement grid with you all so you have the technical report, the technical document.
And then Mildred had also asked, does the risk assessment need to be consolidated into a single tool? Many of these data elements are collected separately.
Yeah, I imagine, because if it's already in your EHR, I imagine they are going to be in different places. I think it will be a hospital by hospital kind of thing. If you already collected in different places in your EHR, your abstractor will need to know where those things are being collected separately, and make sure that, all the points that are included in the maternal risk assessment were completed. I imagine that for hospitals that don't collect that in the EHR and are going to be using the paper form, they will probably, use a checkbox to say, was the maternal discharge assessment completed in the paper form, and maybe collect that. I believe that's going to be specific to each hospital process. But if you collect that in different places in the EHR, just make sure that your data abstractor knows where those places are, and verify that all the components of the assessment are included.
Again, there's a question about the data forms, and they are in the toolbox for the PACC Initiative. I've literally have clicked on them where I can see them. So they are in the, so if you get the PACC Initiative and you go down to the toolbox, you should be able to find all the data forms already posted. And if you still cannot get to them for some reason, please email us at fpqc@usf.edu. We don't mean to make it a mental challenge. We'll get them to you if you need them.
Absolutely. Mildred asked us another question. I'm not sure I understand your question, Mildred, so I don't know if you want to come out of mute. We're not collecting reasons for the appointment because the standard recommendation is that all women should get an early postpartum appointment. So there shouldn't really be a reason, but I don't know if you mean something else that you may want to share. Mildred, are you there? Oh,
Yeah, I think we're basically, I'm sorry, basically, just, needing to know if we needed to have that, but it didn't sound like that. It sounded like you, did not have that as a specific question, as far as why the reason was.
Yeah, the reason is just that, you know, it should be a standard of care that all women receive that early postpartum visit, not because of any specific reason. And the recommendation by ACOG is that that can be an in-person, you know, appointment, or it can be a telemedicine. The thing is that the provider needs to contact the patient and make sure that they go through the list of things that they need to check at the early postpartum visit, to make sure that things are going well. So we don't want to be prescriptive of that. We just want to make sure that that early postpartum visit or check is happening, is scheduled, so it actually happens.
And I had one other question way earlier that I didn't see addressed, and that was in the vital sign check just prior to discharge, how many hours counts as just prior to discharge?
So it should happen within an hour. The idea is that, you know, when the patient is ready to leave after you have gone through patient education and all that, that is the last thing that you check before that patient goes out the door. We didn't want to provide any specific timing because, again, we know that processes are different in each facility, but the idea is that it happens as close to discharge as possible.
Mildred, you need to figure out what's best for your hospital. Obviously, the closer to discharge, the better. Again, the problem that we've been having in the mortality review is we'll have women who go home with 120 heart rate at the time of discharge with no workup. A pregnant woman should not have a heart rate of 120. Other women have gone home with rapid ventilations. So our key is we're just trying to make sure that women are not going out the door with signs of more important issues that are still going on. So figure out in your environment what's acceptable, but I would say 8 hours is way too long. Does that make sense?
Yes, thank you.
Right. We are over the time. I want to be respectful of everybody's time. I don't see any other pending questions, but if your question wasn't answered or if you have any other questions, please don't hesitate to email us. There is our email or my email if you want to send it to me. Again, thank you so very much for attending today. We are more than happy to follow up, and thank you for participating in PACC. It will great to, we will connect again in person in the coaching call, in person, but virtually in January's coaching calls. And in the meantime, I wish you a wonderful week.